Hello, I'm Hannah Donnert with the Collaborative on Health and the Environment. Che enjoys bringing you the latest environmental health science through our partnership calls, webinars, science serves, publications, and social media. I would like to welcome everyone to today's webinar titled Indoor Air Quality in Schools and Childcare Facilities During COVID-19. This is the fifth webinar in Che's ongoing series on COVID-19. Our moderator today is Karen Wang, Director of the Collaborative on Health and the Environment. We will leave time following the presentations for a brief Q&A session. You may type in questions to the Q&A feature available on the menu bar at the top of your window at any point during the presentation. After the presentation, our moderators will read out questions, for our speakers to respond to. We will get to as many comments and questions as we can during the Q&A period. For those of you who called in on the phone, we have posted slides to accompany today's webinar on our website. You can download these by going to healthandenvironment.org. Please scroll to the bottom of the page and select today's webinar. On the webinar page is a link to the slides. Everyone on the webinar right now is muted with the exception of our moderator and our speakers. This webinar is scheduled to last for 60 minutes and is being recorded for our call and webinar archive. With that, I'll turn things over to you, Karen.
Great, thank you so much, Hannah. During the COVID-19 pandemic, the need for science-based solutions has never been more evident. Our webinar series that Hannah mentioned on environmental health and COVID-19 are intended to share the most current evidence-based science. We've had webinars on safer cleaning and disinfecting at home and in childcare and school facilities, water quality in buildings that have been vacant, and on air pollution and pulmonary health. All of these recordings are available on our website, healthandenvironment.org. Today, we're very excited to have two excellent speakers present on indoor air quality in schools and childcare facilities. As a parent with a kid in school, I know how deeply important this topic is, top of most people's minds with kids. And with winter approaching, making outdoor learning less feasible, and many schools and childcare facilities either open or considering reopening, the science on indoor air quality is critical to establishing and implementing best practices for the safety of students and staff. Our first speaker today is Dr. Shelly Miller. She is a professor of mechanical engineering and faculty in the environmental engineering program at the University of Colorado Boulder. Dr. Miller is an expert on indoor environmental quality, including airborne infectious disease transmission and control and air cleaning technologies, and will be discussing COVID-19 transmission routes, super spreading events, including her work on the Skagit Valley Chorale outbreak, as well as discussing the benefits of ventilation, filtration, and germicidal UV light. Our second speaker is Dr. Jensen Zhang. He is professor and director of Building Energy and Environmental Systems Laboratory, Department of Mechanical and Aerospace Engineering at Syracuse University, and a visiting professor of the School of Architecture and Urban Planning at Nanjing University in China. Dr. Zhang is an expert in room, air, and contaminant distribution, material emissions, air purification, building enclosure performance, and simulations for intelligent control of buildings. Today, he will present his recent publication, which evaluated the potential and limitations of different indoor air quality strategies, including source control, ventilation, and air cleaning purification, and how they can be integrated together to reduce the risk of SARS-CoV-2 infections via airborne transmissions. So I'm going to hand it over to you, Shelly. Thank you so much for being with us today.
Thank you. It's great to be here, and thank you for this invitation. I'm going to start my presentation by sharing a video that we recently made for this webinar. I have a slide that explains airborne transmission, and I thought this is just so complicated to describe on a slide, so I decided to make a video, and I'm going to start by sharing that with you now. Let's talk about transmission of respiratory infectious diseases. Respiratory infections are transmitted between two people when one is infectious and the other susceptible to infection.
When the infected person talks or coughs, they release a mist of particles made out of respiratory fluid that contains the virus. They can throw between 900 and 300,000 liquid particles from their mouth. These particles are less than 1 micron up to hundreds of micron in size. By comparison, the thickness of a human hair is about 100 microns.
One way to get infected is by contact transmission. When you touch a surface that has been contaminated by a virus and then touch your eyes or nose, you can get infected. There is not much evidence at all that this is the way you can get COVID-19.
The second way is when a spray of large particles, like a drop of rain, fly out of the infected person's mouth and land on your eyes, nose, or mouth. To get infected by this route, you must be close up to a person.
The third way you can get infected is by inhaling virus-containing particles that are floating in the air. This transmission route is called airborne or aerosol transmission. Some people think of an aerosol spray can of deodorant when they hear the word aerosol, but really an aerosol is just a bunch of particles suspended in the air.
Getting infected this way could happen by either being close up to a person, called short-range aerosol transmission, or when you're far away from a person, called long-range aerosol transmission. Animal studies, air sampling, and super spreading show that SARS-CoV-2 is transmitted by breathing in aerosols.
SARS-CoV-2 is an overdispersed pathogen like SARS and measles. This means as few as 10% of people transmit 80% of the infections, and many people barely transmit. Most infections happen within households, where 1 or 2 other people may be infected within your own bubble. Also unique to SARS-CoV-2 is that many transmissions are pre-symptomatic or asymptomatic, so you literally have no idea who is infectious. People are most infectious right before they have symptoms of the disease.
To prevent infections, we must control both short-range and long-range airborne transmission. Short-range is when you happen to be in close contact. If you are as close as 8 inches, you can get infected by a spray of large particles landing on your face. Between 8 inches and 6 feet, you will inhale the virus.
Long-range aerosol transmission also happens. This is how super spreading occurs, when you have a series of unfortunate events that happen all at once. A highly infectious person is indoors for a long time, shedding lots of virus, and there are also many susceptible people in the same space. The airborne virus begins to spread through the indoor space and builds up to high levels because there is poor ventilation, minimal surface deposition, and no air cleaning.
Why is this important? Because the way to minimize the risk is with different strategies. You will never prevent short-range aerosol transmission by improving your ventilation. The only way to prevent it is by wearing a good-fitting mask, staying socially distanced from the person, and quarantining upon possible exposure. And definitely when you start to show symptoms. The closer you are to somebody, the more virus you will encounter, so try to stay at least 6 feet apart.
To minimize the risk of long-range aerosol transmission and super spreading, we must treat this with ventilation and air cleaning, and still wear masks to reduce the amount of virus that you breathe in or that you may release. Reduce the number of people indoors so that the chance that somebody is infected goes down.
You cannot ventilate your way out of short-range transmission scenario, but you must ventilate your way out of a long-range aerosol transmission situation. And always use multiple strategies in case if one fails.
I want to give a shout out to my colleague, Dr. Marina Vance, who helped me do that this weekend, and also to my daughter. She is in 8th grade, heading off to school right now. She gets to go 2 half days a week outdoors in tents, and she still hates it. So it's really hard. It's really hard. All right, so let's keep going. I'd love to share a little bit more with you about my recommendations. I'm going to start this video, with this presentation, with what I think we should be doing, and then I'll fill the middle with why, and then remind you again my recommendations. For short-range airborne transmission, as the video explained, we need to provide surgical masks to all staff and students and mandate wearing at all times in buildings. I know around here that is not the case, and it needs to be. Implement strict social distancing policies. For example, no eating together in the lunchroom. You can eat together outside. Implement strict quarantine as well, especially when you're showing symptoms or have been exposed. But I do not think you need to quarantine the whole school from a couple of cases. In super spreading events where long-range airborne transmission is a possibility, you should aggressively increase your ventilation rate. Your goal should be 5 to 6 air changes per hour. Windows and doors can help you achieve that, but you can also supplement with additional air cleaning. And I do recommend providing air cleaners for 600 to 1,000 square foot rooms, especially with 8 to 10 foot ceilings, and then using UV light for upper room air disinfection in much larger spaces. I also suggest adding carbon dioxide monitors to your space, and I will explain why, because that helps understand how much ventilation you're providing to each classroom. I want to back up and try to figure out what we know to date about school transmissions. The data is pretty interesting. It's not super clear that schools are at all driving this pandemic. What we see is there's no evidence of difference in positivity rate between teachers and other key workers from a study in the UK in as recently as September and October, where we find that teachers and education support staff are comparable to other professions and other key workers in terms of their infection rate. There's no consistent pattern in the data to date. It's not that closing schools lends to a decrease in cases or that opening schools leads to a surge in cases. And this was written by a report in Insights for Education. And the studies are complicated because there's a lot of confounding factors that go into trying to tease out this data. Plus, we're not collecting enough data in very good quality to actually answer the questions we need to be answering. A recent literature review is very good at trying to explain all the studies to date. And in their assessment, they say that susceptibility for children age 10 is relatively low compared to adults, but that mitigation measures should be implemented when opening schools, particularly secondary and high schools. And another study does support that there is a lot of transmission among staff. In the England summer school session, most of the outbreaks were staff to staff and then staff to student. Also some student to staff and very few student to student. And the number of outbreaks was very low. I think right now what we're really trying to reduce the possibility of outbreaks in schools. This is not what needs to be happening. And I think we're seeing that in the England data that does not happen. I also really wanted to highlight that this is an overall, a really important point, that a study out of Yale said overall level of community transmission is a really important parameter. We all know they're going up at very high rates and it's very worrisome. Both policy and social context affects people's risk and outcomes, and that we also see where you live, because you have high transmission or not, and your race and ethnicity really factor into whether you're going to be testing positive or be hospitalized. And this level of disparity needs to be addressed. There's a COVID-19 school response dashboard. If you're not participating in this, I think that you should. It's a self-report option. It's a great opportunity because there is really no other place that's collecting data from all around the schools in the US, as far as I can tell. This was data from yesterday, where we see that student confirmed infection rates are 0.09%, or 6 per 100,000 students. The staff rates are about double those of the student rates. And we are now seeing a significant increase in school reporting. I know I've asked my kids' schools to start reporting on this dashboard as well. Over 3 million students are represented on this dashboard to date. I want to touch briefly on super spreading. I think this is our great fear, that we end up spreading a bunch of virus to most people indoors. It's a pretty, like I said in the video, it's a series of unfortunate events where you have somebody showing up with high levels of viral shedding. And in this simulation modeling study, which was very well done, they show that very high levels of RNA virus shedding is also responsible for very high numbers of secondary infections. And that's the graph on the upper right. On the lower right shows us how we might be able to mitigate these super spreading events, which is that we could either, what we want to do is get the mean R0 of the epidemic down to below 1. So we could either shut down our economies at about 50%. We know America is not going to go for that. So instead, we could also then get it below 1 by curbing gatherings at below 20 people. And if we curb them at 10 people, which is what the state of Colorado has since mandated, then this is how we could get that mean R0 below 1. We analyzed the Skagit Valley Chorale Rehearsal outbreak that happened in March, and we used the Wells-Riley equation to estimate the emission of infectious airborne dose. My colleague, Dr. Zhang, will talk about that next. And then we wanted to explain how we could change the conditions, use a layering approach to reduce the risk of getting sick in this event. This is our first real evidence of aerosol transmission, and my colleagues and I, all here on the author list, immediately got together and said, this is aerosol transmission. We have to figure out what happened. We interviewed the Chorale members and we interviewed the facility managers, and we put together this analysis. The real event resulted in 87% infections of 61 people at the rehearsal for 2.5 hours. If you then decide, I'm going to change one thing in this event to see its effect, no matter what you do, one thing will reduce your risk by 50%. You can adjust the ventilation, you can do some air cleaning, you can give everyone a mask, or you can even shorten the duration time. Again, you're going to only reduce your risk to 50%. So we need to do them all. And that is why we are promoting this layered approach, or you can move the event outdoors. I'm also involved in the musician and performer study, where we got together in June and said we need to save music at the behest of NFHS James Weaver and Clemson's band director Mark Speed. We collaborate with University of Maryland and University of Colorado, team together, and have been working on this problem for 6 months. I'm only going to share one slide here, but we are releasing a new set of data and recommendations this week. Our data in the lab shows that an aerodynamic particle sizer can help us find where the plume is of aerosol in the instrument. And we are measuring the plume coming right outside of this bell, of this clarinet, the picture in the middle, and it is masked with our bell cover. So looking at the total number concentration from an oboe, we see that when we have the surgical mask bell cover, and when we're reading, we have very low aerosol measurements in the chamber, which is a very clean chamber. But then when we take the bell cover off, the emissions increase. And the oboe we're showing here because it does have the most aerosol being released that we measured to date. Our bell covers are quite effective at reducing the emissions out the bell, upwards of 95%. And we also have mask efficiencies in front of the mouth of about 80 to 90% for theater performers and singers. The graphs on the right show the average concentration measured in all of our experiments. And we see the singers, release about 1 particle per cc for the short time that we're measuring. It's just a few minutes. And then when we put the mask on, it's significantly reduced. And again, comparing to the clarinet, we see the clarinet and the singer are both about the same levels, but the oboe is about 4 times higher. And there's really no emissions from a flute. Based on our studies, we have these following recommendations for music programs, and all across the country, music programs have stayed open and marching bands have stayed rehearsing and practicing. And we have no case of reported outbreaks to date for any program that is using our mitigation methods, such as the picture on the left, which is the St. Olaf band practicing using our mitigation strategies, which is to use masks on everything, only play indoors for 30 minutes, allowing time for the room to clean, and make sure you're distancing with good ventilation. I'm just going to speak briefly about ventilation, filtration, air cleaning with regards to schools. I want to touch on one thing. What is the right ventilation rate in an infectious disease outbreak? Well, what we look at is the literature that shows, if we're using low ventilation rates, it could cause an infectious disease outbreak, as we've seen now with the pandemic of COVID-19. In a tuberculosis outbreak in a university in Southeast Asia, we saw that their ventilation was 1.7 liters per second per person, very low. And a tuberculosis outbreak started in November and carried through the buildings. The CO2 was very high in these buildings, 3,200 parts per million, and the ventilation being too low. Immediately, the university decided, okay, we're going to address this with ventilation because tuberculosis is airborne. And so they increased the ventilation to 24 liters per second per person, and the CO2 levels came way down to about 600 parts per million, and the outbreak stopped. So we know that we have to increase the ventilation rate, and 24 liters per second per person is quite high. Right now for schools, ASHRAE recommends 6.7 liters per second per person, although unfortunately many schools are not following or have not met this guideline. If we use this kind of ASHRAE guideline for classes and we apply it to a 1,000 square foot classroom with a 10-foot ceiling, what we can then understand is the design ventilation rate in this space, and that is 455 cubic feet per minute. That's supposed to be provided to this classroom. Now that corresponds to an air change rate of 3 air changes per hour. And that tells us that it would take 20 minutes for 60% of the room air to be exchanged with outside air. So I think for schools, a 3 air change per hour is a minimum target that you need to ensure, but that according to my recommendations and the World Health Organization, other literature, we suggest getting up to 6 at least or higher if you can. We also recommend, and it's been used for decades, it's not a new idea, we use CO2 as an analog for ventilation. In this diagram, we see an infector releasing viral aerosol, and also this is the viral aerosol in red and the CO2 in blue. They both are coming out of your respiratory system, and the CO2 is then exchanged with outdoor air. Now, the particles do a little bit more than that. They can be removed by air cleaning, by ventilation, by surface deposition, and by inactivation. So CO2 is a great proxy for ventilation. It does not tell you what's happening with particles. If you go and take your CO2 monitor outside with, and this is an AirNet monitor, you get 445 parts per million. It used to be 350, right? It's going up. In a car, and you close everything down and you start recirculating the air, you can get quickly up to almost 5,000 parts per million. If you then turn on your ventilation system to bring in outside air, it drops to about 800 parts per million. I recommend putting CO2 monitors in classrooms and maintaining the CO2 level between 600 and 800 parts per million. CO2 was used as a proxy in a great study by Mark Mendel in California, showing that classroom ventilation was associated with illness absence. If you increase the ventilation rate from the current mean of 4 to the California standard of 7 liters per second per person, which meets the ASHRAE guidelines, that would reduce your illness absence by 3 to 5%. And then increasing it even further to about 9 liters per second per person would reduce your illness absence up to 10%. And we can see the data here on the right that shows the mean ventilation rates for different areas of California. And the lower your ventilation rate, the lower this, and it's related to CO2. So if you have a high ventilation rate, you have a low CO2. And so this does give us some understanding of CO2, ventilation, and illness. This is a fantastic study which tried to understand how schools were involved in propagating infectious diseases. It was an extensive simulation done in assessing schools and their role in propagating an infection, an airborne infection like flu in Hong Kong. They simulated real schools and real contact networks. So that means as a parent, I could infect my kiddo, or my kiddo could go out with me to the restaurant, and then we could be exposed there, and assessing all the different places you could possibly get infected, including the schools. And then they looked at all the mitigation measures that we would use in a school. What we see is that there could be a 9% decrease in the baseline infection rate by using these 3 scenarios that could be implemented in schools. The first one is to actually focus strictly on ventilation rate, which is to increase school and home ventilation rates to 5 air changes per hour. Now, home ventilation rates are typically under 1 air change per hour, so we need to ensure everyone was improving their home ventilation rate. Then you could go to either increase school and home ventilation rate, or do 100% isolation of all cases of disease. And then you could also add, well, let's close the targeted schools at 5 cases. And we see that that does not give us incrementally much more safety in infection. Harvard has some really great information out on how to keep your school safe and what to do. The reason I point this out is that when you are opening your windows, you can increase your air change per hour. So the mechanical ventilation in this data showed us about 2 air changes per hour. You open the windows, you can get up to 4, and you open the doors and you can get up to 6. We have a little bit more on air cleaning, which is that we want to quantify the air cleaner performance using the clean air delivery rate. Please make sure every air cleaner you purchase and put in a room is sized appropriately for that room. And if it's sized appropriately, you can get much faster decay in any pollution in your room compared to no air cleaner. In this particular study, we were comparing different bioaerosols, and this holds true for virus as well. The clean air delivery rate of air cleaner 1 was 170 cubic feet per minute. That could clean a 30 cubic meter room. But a $700 very nice looking clean air delivery rate of 25 air cleaner 2 could only clean a 4 cubic meter space. And so there are products on the market that will not do anything for you. We've put together this Harvard CU portable air cleaner tool, and I really recommend, if you haven't used it, to do it so you can size your air cleaners effectively. You enter everything in yellow, put in the square footage and the ceiling height of your space. You put in the clean air delivery rate of the air cleaner you would like to purchase. You tell it, well, I think my school has low ventilation, but it might have good ventilation, and hopefully your facilities managers will help you with that. And then you can see what your total air change in the room will be with your added air cleaner plus your ventilation rate. And I think you want to really target to get up between 5 and 6 air changes per hour. For very big spaces, you also might consider upper room germicidal UV, where we irradiate the upper zone of the room and we keep the lower zone, the occupied zone, free of radiation. We are designing systems like this currently for homeless shelters, and we have used them in healthcare facilities and hospitals and other places. We have provided detailed guidance to the CDC on how to do upper room UV, and that is found here. But I want to point out that another study showed that UV was singly the most effective approach combined with isolation and vaccination against airborne infectious diseases. So again, conclusions. I'd like to leave you with 3 important ideas. One is that there's devastating consequences to kids being out of school. It's a national priority. It hasn't been. It's been poorly handled, and we need to do better. The return to school should be prioritized over other aspects of the economy. It should be the last to close and the first to reopen, specifically in this pandemic where we do not see a lot of data showing that schools are driving the pandemic. We cannot do school as usual. We need to do a layered defense risk reduction strategy. We know that the infection and fatality rate for kids is very low. The overall risk lens has to include number 1 and number 3. Number 3 is designed to protect both kids and adults in the school. and leaving you again with my conclusions on how to prevent short-range transmission resulting in a few cases and making sure you're not going to end up with a super spreading event. Thank you very much.
Great. Thank you so much, Dr. Miller. We're waiting for Dr. Zhang to pull up his slides. While he's doing that, we have a lot of great questions already in our Q&A, but I'd recommend that you guys, if you have any questions, feel free to put more in the Q&A box, and we'll try to get to as many as we can. Thank you, Dr. Jensen.
Thank you, Hannah and Karen, for organizing this seminar. And thanks to Shelly about great presentation. It's very informative. It covers a lot of cases and practical measures to mitigating the risk of infection. What I'd like to share with you today is integrating IAQ control strategies to reduce the risk of COVID-19 infection. Much of the materials, I think, Dr. Miller already covered, and I try to get into some of the principles of IAQ control strategies. So this is a quick overview, and I will briefly introduce, after a quick introduction of the indoor air quality control processes, and what are the major emission pathways, which Dr. Miller has already covered quite a bit. So I will try to simplify that. And then I will introduce the IAQ control principle, effectiveness of various IAQ control strategies, including source control, ventilation, air cleaning, and integrating, how can we integrate these IAQ strategies to reduce the risk of infection. And finally, briefly touch on how do we know if the strategies are working. So in terms of air pollution controls, let me move this bars, I think, okay. So this is about air pollution control process. So pollutants, we have various sources. Pollution can come from outdoor, indoors, from people, from materials and equipment or reactive compounds. And then how do we protect the people indoors? So for this pollution to affect people, there's a transmission or transport process. So the principle of indoor air quality control is to inhibit this transport and also remove them, what we call the sinks. And we have three strategies listed here: source control, ventilation, and air purification. Now, first of all, just as you have heard already, that the three major transmission pathways, including the contact, droplets, and aerosols. Most recent studies and more have shown the evidence of aerosol transmission, which can be considered as a major route. What I'd like to add here is that it's not only for the long-range transport, it's also for short-range transport. The aerosol, the small aerosols that generated by people, they are also in a very close range. So they can affect the people's exposure significantly. Now, how to estimate the risk of infection? And Dr. Miller mentioned the Wells-Riley model. So I do a brief introduction here. So the infection risk, or the probability of infection, is defined as the number of new cases divided by the number of susceptible cases in the space. So let's consider a space which has certain ventilation rate and has certain generation rate. And in this space, we'll see that the probability of infection is a function of the exposure. So if we follow this Wells-Riley's model, what we see here is that this I and Q, I is the number of infections, people in the space to start with, and Q is the quantum generation rate. So these two, the product basically is a generation rate, and then we have the P times T, which is the inhaled air volume. So we have basically the quantum generation rate divided by the ventilation rate, Q, which is the concentration level of the virus. And this concentration times the inhaled air volume give us the inhaled viral dose. So in the case study, Dr. Miller presented, or in the other literatures, the famous study in the Guangzhou restaurants. And based on those case studies, one can estimate what is the generation rate and of this quantum generation rate. Now, this equation tells us is that the probability of infection is controlled, is a function of the inhaled viral dose. So if we plot them here, what we can see is that the inhaled dose is 1, corresponds to the 1 quantum of viral dose corresponds to 63% risk of infection. Right? So this is the 1 quantum of viral dose. Now the question is, how can the viral concentrations in the inhaled air be reduced by IAQ strategies? So our objective is to reduce this concentration level. Therefore, we can reduce the exposure. So consider this diagram here, this space, which is ventilated by this air, excuse me here. So ventilated by the supplying air to the space and through an air jet. This air jet actually mixes the space air and also the pollutants. And through the mixing and the exhaust this pollutant containing air, then we have the dilution. So this is dilution by ventilation. This dilution air can also be provided by air filtration in the system, as you can see from here, air filtration purification in the HVAC system, which means that we need to also have the recirculated air in order to take advantage of these circulations. So the principle of IAQ control, our goal is to control the concentration below a certain threshold value on the criteria level. And if we look at the mass balance in terms of viral mass balance in the space, so this concentration level is governed by the equations as shown here. That basically states the rate of contaminant accumulation in the space is equal to the rate of source emissions times the rate of dilution by the ventilation and rate of reduction by air cleaning. So we can improve the air quality by reducing the rate of source emissions, increasing the rate of dilution by ventilation, and increase the rate of reduction by air cleaning. So we can integrate all these IAQ control strategies to reduce the rate of contaminant accumulation. Now, so these are the three strategies. And what's important to note is that air cleaning only works for target pollutants. Now, in this case, what we are interested is in the particles that containing the virus. Now, if we look at ventilation and air cleaning, combine this into one term, which we call the equivalent total ventilation rate. Now, this equivalent means it's equivalent to ventilation, but only for the target pollutants. And so at a steady state, and then we have this concentration level is simply equal to the rate of emissions of the viral emissions in the space divided by the equivalent total ventilation rate. That includes both outdoor ventilation rate and also the dilution power from the air cleaning devices. So let's look at these slides, spend maybe a minute on this one. So the horizontal axis here represents the acceptable concentration or odor quantum intensity. We call the C, the threshold value criteria. The vertical axis is the required ventilation rate or clean airflow rate that is necessary to maintain the concentration below this threshold value of concentration. So in a typical case, let's say if we have a load, this light blue line, light green, represents a typical load case. Then if we have a pollutants, for example, the bioeffluent, like every one of us will emit a certain bioeffluent, and for odor control, then we have to have certain ventilation rate. For example, actually standard look at 5 CFM per person. Right? And if you are dealing with particulate matters, and we require a higher ventilation rate. Now, if we are looking at a particular pollutant in indoor air quality, often we've been dealing with formaldehyde because it's a carcinogen emission. It's a typical emission from different building materials. But in this case, we look at the viral quantum. So to reduce the quantum intensity below a certain level, we would need even a higher ventilation rate, as you can see from this arrow. Right? Now, regardless of what pollutants are in there, and we still need to maintain what we call the minimum ventilation or clean air for the unknown pollutants, because there are many pollutants indoors at the trace level, and we may not be able to measure. We don't know them yet. So a minimum ventilation rate is important. We cannot replace ventilation rate with air cleaning. However, the air cleaning technologies can be used to target on the pollutants, and therefore we can reduce the amount of ventilation that we need to bring from the outdoors, and therefore we can actually save energy. At the same time, keep people safe. So this delta QE is the effective, total effective ventilation rate that's needed to maintain the concentration level below this acceptable level, below the C criteria. So let me, next I'll just briefly introduce, look at the answer the question, how effective are various control strategies? Source control is always the first thing we would look into in terms of the IAQ control. And obviously we can do the test and the quarantines to eliminate or reduce the chance of having virus carriers in the space. Hand washing, sanitize surfaces, and flush out disinfectant residues before occupancy. And these are also very important. Now here, I just want to mention that people people use disinfectant to clean the space, and following that, the air should be flushed out, well flushed out, because some of the infectants actually has a residual effect on indoor air quality, even though they can kill the virus itself, but they can cause other problems. EPA has recommendations on the safe disinfectant to use. So you may want to refer to the EPA website for recommendations. Now here, in terms of aerosol transmission, how do we limit that? The wearing a mask is a very effective way to reduce the emission from asymptomatic or pre-symptomatic virus carriers. It can reduce by 30% to 95%, depends on what kind of mask you use and how the mask is worn. So I personally recommend the surgical mask, which will provide 75% or a basically reduction of the risk by a factor of 4. And of course, this is assuming that people will wear it properly, it's tightly fit. And so this is very important. Otherwise, the efficiency would reduce. But even for closed mask, it still has 50% efficiency and give us a factor of 2 reduction in terms of the infection risk. The other one is the source control, very effective way, is the local exhaust, reduce cross-contamination by a factor of 2. This was a study done by my colleague, Professor Zhang, and his former student that look at the in an airplane application that you have 2 people here, 4 people sitting here, and one is emitting the pollutants. And if there's a local exhaust on top of this person, then we can contain these pollutions and significantly reduce the contamination, cross-contamination from this the source person to the ambient person, to the people beside him or her. And they also did actually experimental study to test this out. And so this was verified. And basically the local suction concept has the potential to reduce pollution due to occupants by a factor of 2 without increase of energy consumption. The second strategy is ventilation. So ventilation has several, when we talk about ventilation, first, it has to have clean air, clean outdoor air. And secondly, it has to have enough outdoor air. And thirdly, we have to deliver the clean air to the occupied space. Now, by doubling the outdoor air ventilation rate, and assume we have a well-mixed indoor environment, then it can reduce the risk of infection by a factor of 2. The displacement ventilation, instead of using mixing ventilation, so this displacement ventilation can further reduce the infection risk by a factor of 2 by increasing the ventilation efficiency, basically deliver the clean air to the people more efficiently. And briefly, in this system, displacement ventilation, we would introduce airflow at the lower part of the space at a lower temperature. So this, because it's a cooler temperature, it's spread over the floor. And when it hit this heat source, like people, and this heat source will generate a thermal plume and bring this air up and resulting in a higher temperature above the occupied zone. So it causes a stratification in the occupied zone to reduce or minimize the mixing. So it's just opposite to the mixing ventilation system, that we actually want to reduce the mixing in the occupied zone. Therefore, any pollutants, or let's say the virus emitted from a particular person would be moved up and exhaust to the outside or filtered out by the filtration system. So this is the principle of displacement ventilation. Now, if we integrate the displacement ventilation with called semi-open partitions, and it's very effective. Okay, it can actually increase the reduce the infection risk by a factor of 20, and this is very high, very effective. Now, of course, in this case, we have to be very careful in installing the partitions. If you just buy a bunch of plexiglass installed in the classroom, you think they can separate the aerosol transmission. That is not correct. Okay, and it has to be very well integrated with the airflow pattern, air distribution. So in this case, for example, in this scenario, we would have to provide air to this space and then have a partition, this cool air that will rise up. You see this two plume rise up, and this partition between these two. And because of the principle of displacement ventilation, these pollutants will not come down, will not flowing down. So it will be exhausted at the upper room. So that will help basically significantly reduce the cross-contamination between the two people, which means it will reduce the person-to-person transmission significantly. If you only have a mixing ventilation system in the classroom of office spaces, and it's still effective, but you have to place the partitions so that arrange it well with where the diffuser is placed. And so this does require some expertise, professionals to design the space. So it shouldn't be implemented just by sort of randomly place the partitions in the space. And the professional should be asked to look at the airflow patterns. And that's why I call this strategy is more intermediate strategy. It has more involvement in this case, but it can be done. The other one is the personal environmental control with local air supply and the local exhaust. And of course, that would be the ultimate personal protections. So in terms of ventilation, what I just mentioned, so deliver clean air to occupants and dilute and remove the pollutants. So the mixing type ventilation is maximize the mixing, while displacement ventilation is to reduce the mixing. And personal ventilation is you have good, very good, isolated environment and provide individual ventilation and exhaust to the outside to avoid any mixing, cross-contamination between here and another space. So the third strategy is the air cleaning and purification. So air cleaning can be applied in two places. One is in the central systems, like air filtration. The other one is in-room air purification here. So if we in the central system, and by increasing this, normally we have MERV 8 filters in the system, and we can increase that to MERV 13 or higher for better filtration. Now, what's important that the filtration effect or this effective airflow rate is the product of airflow rate and filtration efficiency. So if you have a highly efficient filter, which is, let's say, HEPA filter, for example, very efficient, 99.9%, here. But it has to have enough power. The fan in the system has to have enough power to push enough air through the filter in order to achieve this factor of 4 reductions. But most existing HVAC systems cannot handle that. Therefore, it will require major system renovation, which can be costly. But a MERV 13 filter, if you look at MERV 13 filter here, it can already increase the reduced leaks by a factor of 2 to 3, and which can be handled by most of the HVAC systems. So after the central system, I think filtering the air in a central system, the quality is easier to maintain. Like you can maintain the uniformity, and you have the facility managers to make sure the air filter are installed properly. There's no leakage, and that enough sufficient airflow rate, and that can be commissioned to make sure it does perform. Now, in addition to that, one can also add room air cleaners to provide additional flow rate CFM, 10 to 15 CFM per person, and which can reduce the risk by a factor of 2. I think Dr. Miller mentioned about this. It's a very nice tool that Harvard and University of Colorado jointly developed, and that can be used to specify the amount, the size of the air cleaners and the number of air cleaners depending on the space requirement. My recommendation here is to have 10 to 15 CFM per person.
Dr. Zhang, this is Hannah. I just wanted to give you a time warning because we're coming close. We've got a lot of questions for both of you.
Okay.
Thank you.
All right. So how many more minutes I have?
If you could close up in the next minute, if that's possible.
Oh, okay. All right. Sorry about that. So, okay. Yeah. So, and of course, one also should wear a mask to reduce the risk. Mask can not only reduce the emission, but also reduce the inhalation. And this is just showing that, just to say, the same technology for air cleaning can be very different for different pollutants. And we also have to observe, make sure that there's no ozone emissions or other unintended consequences due to the use of air cleaning, because the ozone can actually itself is a pollutant. It also react with various compounds, including the skin oil that can generate additional pollutants. So we can integrate these various control strategies at a multiple scale, at a person scale, cubicle, room, room scale and building scale. And now if we apply this to a classroom, as an example classroom, this is what we measured at some times ago for a different study. I just use that as an example. It's about 1,000 square feet classroom, 10 feet 10 feet high ceiling with 50 students capacity. And we measured the airflow rate. It actually has 500 CFM, about 10 CFM per person. So this is fairly well ventilated space in existing situations. Outdoor air fraction is 20%. So if we assume there's a one virus carrier at the beginning and generating 100 quanta per hour, and then we can estimate what is the probability of infection. So this infection, you can see the infection, probability of infection is a function of the equivalent ventilation rate above the baseline in this case. So we start with the baseline. You can see here, that is the, if we don't do anything, no filtration, just use the existing ventilation, that's the risk. We talk about the 13% of risk, okay? And if we apply the source control, we can reduce it by a factor of 16 by requiring everyone wearing the surgical mask. And we can double the outdoor ventilation rate, and this is, we can reduce by another 50%. And this shows the effect of MERV filters or HEPA filters, which is converted to equivalent ventilation rate CFM per person. We look at CFM per person, okay? And if we combine this technology, let's say use MERV 13 plus double outdoor ventilation rate, plus 20 CFM per person clean air, and or even increase more to 40 CFM per person using room air cleaners, and we can actually reduce this risk. And as a comparison, and to what level we have to reduce the risk, and like 0.27% is a sort of a car accident per 1,000 miles. And of course, odds of deaths due to car accident is 1%. So this gives a sort of a reference what kind of risk we are dealing with. So how do we know that these strategies are working? We can do system commissioning, monitoring, maintenance. Quality assurance is very important by training, education, and enforcement of the established safety protocols, and documenting. Like what Dr. Miller has shown, so many case studies that shows the schools actually is not a major place that has promoted spread, right? So, but we need to document those cases to see, okay, what are the ventilation or air cleaning conditions, so we can use those data to set up the proper guidelines. So with that, I close my presentation, and thank you very much for your attention. Sorry for taking a little longer to finish this. Thanks.
Thank you so much. We have a lot of questions, so we're going to try to get to as many of them as possible. Many people have asked about where the slides are, or the recordings and the tools that the speakers mentioned. They're all available on our website. So I'll start off with a question for both speakers. I think that many of the questions and chats have touched on the lack of clear policies and baselines for schools. So if both speakers could comment as to, if you could set a guideline for a baseline of what should be done in schools, and somehow magically that could happen, what would be your wish?
Well, that was what my last slide, that's what my first slide and my last slide shared with everybody, what I think should happen in schools. And so you can refer to those first slides, which is to address short range aerosol transmissions immediately, and then long range transmission so you don't have any outbreaks. So that's there. And I'll pass on because I know we're short on time.
Dr. Zhang?
Yeah, actually, I realized I missed the last slides, the summary and conclusions. I think based on the existing studies that to control the spread, we need to improve the equivalent ventilation rate by a factor of 7 as a minimum. So I think now this, of course, it's very difficult to achieve just by increasing outdoor ventilation, and that's going to cost a lot of energy in extremely hot and cold environmental conditions. So we have to apply the filtration plus the ventilation. So what I always recommend is try to double the ventilation first, double the outdoor ventilation, and then supplement the ventilation with air filtration or room air cleaners.
Okay. We had a lot of questions about surgical masks versus cloth masks. Dr. Miller, I noticed on your slides you mentioned surgical masks, and Dr. Zhang, you said that as well. Could you just talk a little bit about why surgical masks versus cloth masks? Should participants try to get staff and students to wear surgical masks instead of cloth masks?
So to me, the reason I recommend that is because I feel like they can be more consistent. In every study I've seen, they do show a little bit higher efficiency consistently. And so you can maintain consistency and effectiveness across your whole population. And that makes me more comfortable in terms of an approach. The cloth face coverings need to be, double ply and good fitting, and and I think they can vary and they're a little bit lower in effectiveness, but it's better than nothing.
Yeah, I agreed with that comment. I think consistency is very important, and also the surgical mask, they have a better efficiency, can deal with the small particles and filter the smaller particles more efficiently.
Okay, great. Let's talk a little bit about outdoor air ventilation. As it's getting quite cold in some places in the United States, could you talk about opening windows and doors when it's quite cold outside? People have asked a couple questions about fans. Should you put a fan in front of the window? What are the risks of using fans in those situations?
Well, I can maybe share a case study which I personally involved. Is my daughter went to a dance studio, which has ballet dance studio has a very low ventilation rate. So they have to open the windows. So I made a suggestion: you can turn on the exhaust fan and let the bathroom door open to the studio space, and have with the fan on, and then the windows on the opposite side open, even a small crack. It helps introduce a lot of outdoor air in. That I think now people can also, if there's no exhaust fan that the space can access to, you can place a box fan on one side, and then have window on the other side being open. So in this way, you can create a airflow pattern that can remove the pollutants, any possible virus. So that will help. Now, if it's winter, I think this is a very tough situation. I think it does consume a lot of energy to heat the air, so the cost will be high. And I think that for the safety, certainly it's worth it. And I also have recommended if they cannot, they have concerns about maintaining the temperature in the space, because the heater has a certain capacity limit. So I recommend to use room air cleaners in this case. And it's relatively low cost if you look at it. It is standalone air cleaners to give, like 10 to 15 CFM per person. And that's quite a viable approach. So they are actually adopting that, and seems it's working well. And so far, there's no infections occurred. Even there was one case that one person was tested positive, but none of the other dancers and staff were infected. So this is just one data point. I think at least give us some confidence that if we apply the IAQ strategies properly, I think we can manage the risk. We won't be zero out the risk, I think we can manage the risk to an acceptable level.
So Dr. Miller's going to have to jump off here. We're running out of time. So I'll go ahead. We can keep you, Dr. Zhang, for a couple more minutes if there's any other questions, Karen. And Dr. Miller, thank you so much.
Yeah, I have a question that some people talked about in the chat. Are these strategies that you talked about the same strategies you would recommend for retailers, workplaces, other public spaces?
Yeah, I think the strategies are the same, yes. But how you apply it and which one to apply depends on specific scenarios. So one of the, I would always start with the basic strategy. I think Hannah, you may have my earlier slides. If you can put up the last slide. Somehow I deleted. There are some recommendations, the last slide. Basically, I think I would start with the sort of something that's easy to implement, relatively universal to different spaces, that including increasing the ventilation rate and within the limit of the capacity of the system, of course, and then install a MERV 13 filter over a MERV 8 filter. Keep the recirculation on. I think it's very important. This is the one thing. If you have a filter installed, like in our homes, like most of our homes, we have a habit to run the heating system or cooling system based on called auto setting, which means only when heating and cooling are called for, the fan will be running. But in that case, if there's no heating and cooling required, the fan is not running, then the filter is not doing anything to reduce the risk. So I think we need to make sure that the recirculating air is always running, regardless of whether it's heating or cooling. So after that, then one can apply the personal room air cleaners. And in some cases, I think it again depends on the space. If it's a large space, tall space, one can actually use the upper room UV GI. So I think. Oh, Hannah, sorry, this is not the one. I have another slide, but no, I will add back. I think for some reason it's a summary and conclusion slides. I mistakenly deleted when I add these slides. Okay, but we will add back.
While Hannah's finding the slide, we had a couple of questions about, what air purifier, what CO2 monitor. Could you just answer that question? And then also, could you go over again, what is the importance of the CO2 monitor?
Yes.
And how classrooms and how teachers and administrators can use the CO2 monitors?
Yes. So I'm showing these slides. Can you see these slides? Yes?
No, not right.
Oh, I need to share, I guess.
Yeah.
Sorry. Well, it's last slides. Okay, how do we know if the strategies are working? Hannah, if you can share that slide, it'd be great. So basically, if you look at the monitoring, you can use CO2 as an indicator of outdoor air ventilation rate. So actually standard typically has basically allows 700 ppm above the ambient level. So which amounts to about 1,000 ppm, 1,050 ppm, assuming 350 ppm outdoors. And if we double the ventilation rate, this will get to about 700 ppm. That corresponds to what Dr. Miller recommended, that your the CO2 level should be below 700 ppm, right? And this is by doubling the ventilation. However, this may not be sufficient to reduce the risk not to low enough. So we have to look at called equivalent reduction of 7-fold is needed, which means we really need to reduce it to 450 ppm in order to control the risk in many cases. But this level of reduction is not reflected in the concentration of CO2 because we are talking about removing the particles, and this is equivalent to this reduction. So I think at least with CO2, one can measure whether we have sufficient outdoor ventilation rate, and then I would check on the flow rate, the actual air flow rate. For example, the building energy management system, typically they would record the flow rate, how much flow rate is total supply air flow rate in the system, which can assure that filtration system is working. The CO2 sensors are, there's a variety of CO2 sensors, and you can have relatively expensive one. I bought one just for study, and that carried with me. It has about like $700. That's probably too expensive for each classroom to install. And there's, I think, the lower cost one, about $100 a piece. I think it's and those are available, and being able to monitor that. I think it doesn't need to be monitored all the time. If you have a school, let's say you have a school have a cup, one or two, and there's someone to check, using that to check different classrooms to make sure a system is working, and on daily basis, and that will be sufficient. It doesn't need to be monitored all the time, in my view, because it's just too expensive for many schools. Yeah.
Okay, one final question, because I know we're over time. We had a couple people ask about if you have a central HVAC and you're recirculating air from different rooms, does that increase the chance of like cross infection from one cohort to another?
Well, so the answer is depends, right? So if you don't have the filtration system in the system, it will obviously impact increase the chance of cross-contamination between rooms. That is possible. But the HVAC systems are equipped at least with a MERV 8 filter. So if this MERV 8 filter already is equivalent to about 17 CFM per person. Okay, in the classroom example I've gave, if the system has a MERV 8 filter, it is equivalent to 17 CFM per person. It's almost double the outdoor ventilation. Actually, it's more than double the outdoor ventilation rate in that particular case study. So recirculating, keep the air recirculating through the filter actually helps. And of course, you want to, as a recommendation, is you increase that filter grade from MERV 8 to MERV 13, and to further enhance the filtration.
Okay, I actually realized that there was there were some questions about UV that I was hoping to catch Dr. Miller on, but I'm sure you know about them too. Could you talk a little bit more about the UV light? Is that, I think there's a little confusion around how that would be used, how that's different from UV sanitation of objects versus in the air. Could you just go over that just a little bit more?
Sure. So I think in terms of the virus killing capability is the same. The principle is the same. Basically, the UV in particular is UVC. It's very short wave that can penetrate the cell and kill the virus. But in the aerosol transmission control, we have to bring that aerosol, the virus, to the UV. So that's why the system is called upper room UVGI. So imagine you have a space at 10 feet high ceiling, 10 feet or even higher, 12 feet high ceiling, that the occupied zone is only up to 6 or 7 feet high, right? So if we have upper room UVGI and then have the air move this possible virus to the upper room UVGI, and then this UV can disinfect the virus up there, and then basically generating more what equivalent clean air to dilute the space. So it's matter. I think the main difference is how you bring these aerosols to be exposed to the UV for disinfection, comparing to the surface disinfection by UV.
Okay, great. Okay, we are 15 minutes over time, so thank you so much for your time, Dr. Zhang, and Hannah, I'll hand it back to you.
Great, Dr. Zhang. I think when you sent me your PDF this morning, I didn't have the most updated, so I'm going to go ahead and make sure that's updated for our audience that's still on. So you'll be able to check back in about an hour on the PDF PowerPoint to make sure that you see the fully updated version. And I wanted to, with that, thank you, Dr. Zhang, for all of your time and expertise that you've shared with us. And to Karen, we're approaching the end of today's webinar. A video recording will be available on CHE's website soon, and tomorrow you will receive an email containing a link to the video. The next CHE Partnership webinar will take place this Thursday, November 12th, and is titled Racial Ethnic Differences and EDC Exposures. To learn more and to RSVP, please visit our website at healthandenvironment.org. If you are new to CHE and would like to stay updated about upcoming events or more, please sign up to receive our newsletter by selecting the Join Us tab at the top of any page on our website at healthandenvironment.org. Additionally, if you appreciate these CHE Partnership webinars bringing you the latest environmental health research for free, we encourage you to support CHE's ongoing work by making a tax-deductible donation via our secure website. Again, our website is healthandenvironment.org. With that, I would like to thank our speakers, Dr. Shelly Miller, who's no longer online with us, and to you, Dr. Jensen Zhang, for all of your time and for presenting today, and to you, Karen, for your excellent moderation. Thank you so much. Stay well and healthy, and have a great day.